uh, November OEB board meeting to order. And our first action is to, after I welcome you all, welcome, to approve the September 5th board meeting minutes. And after that, we'll approve the October 3rd board retreat synopsis. So any issues or questions for the September board meeting minutes? Otherwise, I'll accept a motion to approve.
I'll move to accept the minutes as presented.
And I'll second.
Okay, that'd be Bill. Okay, and Robert seconds. All in favor, say aye.
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 Opposed? No opposed. Unanimous. Thank you. Now for the October 3rd board retreat synopsis. Any questions? I had sent in just two incredibly little just edits, so you did not get that sent back out because it wasn't an issue. A motion to approve?
I can motion to approve, or whoever that was. I'll second.
I only got you, Bill. I didn't know who did the first.
Oh, so move, Enrique.
Enrique, thank you, Enrique.
Yep.
Yeah. Okay, so now we're on to nominations for OEB's vice chair. Is there anyone who would like to put a name into up for us to consider?
This is Robert. I'd like to nominate Enrique for vice president.
Okay, that's one nomination. Are there any other nominations?
I can nominate myself, but that is, I'm happy if somebody else wants to do it.
Okay, we had Enrique, are you interested?
Yes.
Okay, you talked with Ali about this, about your interest?
I was not.
Okay, that's cool. The only reason that no one had come forward to Ali about being interested in the vice chair, and Bill had said he would be willing to take on that role. He already is the chair of CIAO, and so the fact that you're interested in being vice chair, I think that's wonderful. And so Bill, you've nominated yourself. Would you like to continue with that nomination or not?
Oh, if Enrique is good to do it, then I'll withdraw.
Okay. All right. So is there anybody else that has interest in the vice chair position? Robert, you nominated. Do I have a second?
This is Sue.
Thank you, Sue. Okay, Sue seconds the nomination of Enrique. All in favor of Enrique filling the role for the 23-24 plan year as vice chair, say aye.
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 Aye. Aye.
Is there any opposed? Okay, Enrique, welcome on board. And Ali and Damien will get in touch with you and start talking to you about leadership meetings and things like that. And thank you for stepping forward.
Thank you, Tom. And I want to thank the board, but also Bill. I think Bill is an amazing gentleman and advocate for healthcare. And I want to apologize to the board if I needed to speak to the staff, but that was not part of the rules. So I appreciate the understanding.
No problems at all. Okay. So we are now ready to move on to, we're going to be having 2 benchmarking studies presented to us. And for new board members, the importance of these benchmarking studies are it tells the board how OEB is doing in regards to its offerings for medical, dental, vision, and then we'll get into life and disability benefits in the next one. But basically, it tells us where we are doing in regards to similar organizations that are offering health and other benefits to the people we're responsible for. So that's the basis of this, and it's actually the starting point for our work around the preparing for the 2025 renewal process. So that's the start. And with that, I think John Kessler from Mercer is going to take us through the first part. Is that correct, Kirsten? Okay.
Yeah,
great.
that's correct, Tom.
Right.
This is John. So I can confirm that I'm on for
Great.
the medical.
You're on. Thank
prescription.
you.
Yep. So can everybody hear me okay, or do I need to mic up? Okay, good. I prefer not to mic up, but glad to do so if you can't hear me. After going through the CIAO meeting this morning, I cut down the portion of my lunch and went for a walk before joining this meeting. So again, thank you for joining this afternoon, and thank you for going through this material with us. So as Tom alluded to, the purpose of the benchmarking is really to understand how OEB, and this is done annually typically, how OEB's benefits compare to similar organizations. And the goal in this is to understand if there needs to be tweaks in any areas. So let me just kind of get right to the point, and then we'll go through it. Is there's really, next slide, sorry. Thanks, Rose. We're already to the first slide here. Next one. Yeah, there we go. Thank you. The bottom line is that, things are looking good for OEB at this point, both in terms of the plan offerings, and that's, PPOs, HSAs, and HMOs, and also the benefit design. So we looked at both things, both the plan offerings and the detailed benefit designs, and there are really no immediate needs to make any tweaks in our opinion, or we have no recommendations in that area. But we do have, I think we're really going to have to look, because in the next round of renewals is going to be particularly interesting, because you're going to see that effect of the increasing inflation. And, that's going to come out both in the renewal increases likely and in terms of the actions taken by your comparators to address some of those renewal challenges. Just a few things to highlight, in terms of the PPO benefits, we really focused on the in-network portion, since that's where the lion's share of the care takes place, over 90%. One thing that's a little different this year than in past years, that so in addition to our typical Mercer large employer and regional benchmarks, this year we've added some custom benchmarks that are particularly relevant to OEB. So I think better data points, really. And those include the City County Insurance Services, CIS. And CIS was formed by the League of Oregon Cities and the Association of Oregon Counties to meet the employee benefit needs of cities and counties in Oregon and other eligible local governments. The second additional custom is SDIS, which stands for Special Districts Insurance Services. And SDIS was formed to provide benefits more economically through joint purchasing to special districts. And, just as a reminder, special districts are a form of local government that are created for the express purpose of providing a specific service, such as, water delivery, fire protection, airports, and things such as that. The third new custom benchmark that we brought in is the School Employee Benefit Board, SEB, which is essentially OEB's analog in Washington State. So, just that gives you some background in terms of those things. So then let's dive in. So next slide, please. So medical, we're going to start out with PPO since that's where most of your enrollment is. So this is MOTA plans 1 through 5, just to kind of track with that. And again, a lot of this focuses on the CCM, so the coordinated care model membership. And as you heard this morning, that's well over 70% of the MOTA members, the MOTA PPO members, are in the CCM. So just kind of going down through these, the major benefit categories in terms of deductibles, really not recommending any action there, for the next round or for the next round of renewals, since OEB, the OEB plans tend to fall on the lower end of the range in terms of the deductibles. Much the same story when it comes to the copays and coinsurance. They're in line with your comparators. A quick note on that, though, is the non-CCM, PCP, and office visit copays are higher than comparators, and this should not be a surprise. This is really something that's really intentional, in the sense that you're trying to encourage people to enroll in the CCM, and this is one of the ways of doing that, is having slightly richer benefits for CCM, people who are aligned with the CCM plans than the non-CCM plans. One place that we definitely need to monitor is the out-of-pocket maximums, which are slightly higher as compared to other similar situated employers. And again, I think it's really just understanding how many more people are hitting those out-of-pockets, and also how are your comparators changing those out-of-pockets, given the inflationary environment. So let me just pause there, see if there are any questions. Okay, well, we'll keep moving.
This is Tom. Just a comment. The out-of-pocket maximum has been part of our conversation for the last at least 5 years. This is something that we've been watching, and we haven't been able. It's been around the 3.4% constraint has kept us from being able to address this, but it has been on our radar for at least the last 5 years, and has been a struggle.
Yeah, because it's one of those plan design features that is fairly expensive to change, right? Because it's essentially shifting, risk back to the plans. And I think what you might see in this area with the growing inflation is that your comparators, might be catching up with you over the next couple of years. Okay, so let's dive into, so that was the PPO. So then the next slide, please. This is the high deductible health plans. So these are the HSA, PPO plans. So the MOTA plans 6 and 7. And I think, and again here, really no, in our estimation, there's no changes really required in the immediate term. Generally the deductibles are lower. And I think that the only thing we point out is over time, to understand if there might be an interest in having, a higher deductible HDHP, over time. The other thing is the coinsurance; those are in line with, and again, you're not going to see a lot of copays typically in these type of plans, because you have to get through the deductible for the plan to pay benefits. So that's why, these are coinsurance, and your coinsurance, is aligned with your comparators. And then, a little bit like similar to the PPO, you're seeing out-of-pocket maximums, slightly higher than some of your comparators. So, so again, that hopefully gives you a high level. Unless there are any questions, I'll just keep moving, since we have a fair amount of material to cover here. And here we're going to the HMOs, the health maintenance organizations. So these are your Kaiser plans, with the exceptions of the Kaiser plans that are HD health, HDHP compatible. So I think a couple of things to note, that OEB offers a broader range of deductible offerings than its comparators. And I think that that's something worth noting. The co-insurance and the co-pays on your Kaiser plans are generally in line. So just more specifically, the office visit and the inpatient co-pays are in line. The ER co-pays are lower, and the outpatient surgery copay is higher. So, generally in line. And then, as expected, since you have a broader range of deductibles for your Kaiser plans, you also have a broader range of out-of-pocket maximums. So, that's where how you compare to some of your other plans. Okay, I'll keep moving then. So I'm not seeing any questions. So prescription drugs. So this is a little busy, but I'll try and get right to the point here. Again, overall, things are in line. And it's a little bit different by the plan type, because this is kind of encapsulating all of the 3 plan types that we just talked about, which is PPO, HDHP or HSA, eligible plans, and then HMOs. So let's kind of go through each one of those. And again, we're talking about different tiers of benefits. So generic drugs, preferred brand, those are brand drugs that are on the formulary of the health plan. Non-preferred brand, those are drugs that are not on the formulary. And then specialty drugs are, those, typically higher cost drugs that have, specific purposes. So just to kind of go through this, so if you look across all tiers, and we'll look at this by plan, the PPO cost share is on the higher end of the range. The HDHP is in the range, and again, this is going to be, a co-insurance, not a co-pay based plan typically. And what you often see is, employees are paying 20%, and that's pretty standard. And then on the HMOs, OEB's HMOs, your co-pays for the drugs are on the lower end of the range, and with one exception around specialty drugs. And again, if you want to, if there's a sure cure for insomnia is going through the appendix, because all of the details that I'm going through it can be found there. So again, if you have a desire to dive in more deeply, all that raw data is there. Okay, so then moving into dental. Next slide, please. So in terms of dental, the OEB's offering, you have both PPO offerings, through, typically through Delta, and then you also have managed care options, through Kaiser and Wilmette. I'm sure I'll get this pronounced correctly at some point. Let's see. So the thing is that, let's start with PPO. So PPO, what you're seeing there is that richer benefits. Typically, OEB has slightly richer benefits in a lot of areas in terms of the co-insurance levels, and how a dental benefit is typically structured. It's around different co-insurance levels for different types of benefits. And again, not trying to get too pedantic here, but I think it might be a just quick refresher. So you have the preventive, which is often covered at 100%. The basic, and then major restorative. You have that different co-insurance levels for those types of benefits. So looking across those different benefits, the co-insurances levels and the annual limits are often more richer among the OEB plans. There's a particular standout in terms of the OEB plans, and that's around the orthodontia benefit, which is definitely richer than the comparators. Then if we switch gears and we look at those managed care type plans, those are like the Kaisers and WDC. those, what you're seeing are slightly higher copays for some of those services than comparators. But again, probably not worth making changes right away just because of the inflationary environment. Probably worth looking to see what your comparators do over the next year to address that inflationary environment. Go ahead.
Okay. No, I'm sorry. I was my mistake.
Oh yeah, no worries. Any questions, comments?
So far, for both medical, for medical, the if we had no challenges for the next renewal, we potentially could take on the biggest issue, which is the out-of-pocket maximum. And for dental, there's no that needs more benefits. There's maybe a little bit of flexibility in regards to some of the richer benefits around orthodontia. Is that a fair summary?
I think that's a fair summary. I think the real challenge though for the medical piece is really where the renewals come in.
I understand that.
Yeah.
There are going to be challenges, but if there were no challenges,
Correct. Yep.
Yeah. Okay.
That aside, thank you. Yeah, if you put that aside, yes, then that would be where we are. And I think the other thing to realize is not making benefit changes like there were, no benefit changes were made for the last plan year. That is actually a success, and I think that that's an important thing to understand. Even with the challenges in this last renewal cycle, that the benefits were maintained, which I think is good for the OEB membership. So don't want to lose sight of that. And for the last one are the vision benefits. And OEB has a very broad array of vision benefits, offerings through Kaiser and MODA and VSP. And again, the vision benefits are typically structured around eye exams, frames and lenses. So typically in a typical benefit, you have eye exams are covered annually, as are lenses. And then you see a kind of a difference in terms of how frames are covered. Sometimes they're covered once a year, and sometimes they're covered every other year, and sometimes they're covered every year for children, and then for adults every other year. So you see an array of how things are covered. So, but basically what you're seeing is that, and again, we don't have a Mercer benchmark for the vision. We do for the dental stuff. But what you're seeing for vision, I think that your benefits are very much in line. But the but part of this is really looking, because some of your vision plans have annual maximums, and in an inflationary environment, that's something you're going to definitely want to revisit in terms of, are people able to get what they need for those? Because some of those for some of the more basic plans, it's pretty low. It's like a $250 annual maximum. And is that going to get you the eye exam, the glasses, the frames and the lenses? So I think that there's some question about that going forward, and the need to kind of revisit, as the cost of things go up, do those need to be revisited, to make sure that the benefits are meaningful. So that's something that's going to have to be monitored going forward. And I think if we I think that's, why don't we go to the next slide? I think that's pretty much it. And I think we'll move this section into next month, because I think that there will have discussion of this, so we can kind of just click through these. It's really the process for addressing member requests, and we'll be actually looking to help address some of the member requests next month. So this is just the appendix, so we can move through this, and then move on to our next piece, which I believe is the LAD benchmarking. But I don't want to rush into that. If there are any questions or comments.
Yeah. The only additional comment that I would make, John, is that
Yep.
Around one of the requests for for new benefits actually was part of today's
That's right. IBF.
public comment. So it's just for you to note that that one public comment piece, we're already moving into our member request for new services.
Yep. And I think you're referring to the IBF one. Is that the
Yes,
one?
IVF. Yeah.
Yeah.
Yes.
No, and that is on the list, and it's something that we're looking at. And again, we can kind of go through our approach next month in terms of how we recommend looking through these. Is like, starting with benchmarking, some analysis, just to really understand, the really understand where the request and the impact on the plans, really.
Great. Thank you.
Okay.
Any comments or questions from board members?
Other than that's a very helpful comparison, just knowing where we are right now and where we stand.
Thank you. I think we were
Agreed.
really, oh, go ahead.
I agree.
Yeah, we were really excited about adding in the custom benchmarks this year because I think it brings a more meaningful comparisons.
Okay. Thank you, John.
Thank you. I'll turn it over
Okay.
to my colleague Amanda.
Yeah, Amanda Messler from Mercer, going to take us through life and disability benefits.
Sorry, I was muted there. Thank you so much for having me today. I'm excited to get to meet you all for the first time. So my name's Amanda Messmer, and I work in our specialty practice in our life absence and disability market. So today I've got some information to look at our plan utilization with our plans with the standard, as well as some benchmarking on the disability plans. If you want to go to the next slide. Okay, so on this screen here, you'll see our life benchmarking. And overall, the OEB life and life and AD&D plans are running quite well, which is great to report. If you look, our last two renewals were in 2018 to 2019 and the 2022 into 2023 plan year here. In 2018, the standard did offer some rate relief on the basic life, the optional life, and the optional spouse life. And then again in 2022, they offered yet another decrease on that basic life, optional life, and optional spouse life with additional savings on the basic AD&D, as well as the optional employee and spouse AD&D. Overall, the only plan that I think, we need to keep a bit of an eye on is the basic life and basic dependent life. 88% is still running well, but certainly something I do want to make sure I take a look at every year for you all to make sure it does continue to run well. If you want to go to the next slide. Okay, so looking at the disability utilization there, you offer both voluntary employee paid STD and LTD as well as employer paid disability benefits. The STD is actually running really, really well, which is not something I've seen from the vast majority of employers I work with. Even coming out of the pandemic, most employers are finding that they haven't seen their short-term disability utilization drop back down to those 2019 numbers. But in the 2018 renewal, the standard did offer a 20% decrease on the rates in anticipation for Paid Leave Oregon, which just went live this past September. And both the voluntary and employer paid STD are running significantly better than most employers. I would say for loss ratio, we're typically looking at, 80s to 100 plus right now for most employers. So that was really great to see. Again, something I do want to look at after Paid Leave Oregon has been enforced for a year, just to make sure that the rates that were offered on both employer and employee paid are fair, as we could see some changes to utilization with Paid Leave Oregon, and certainly smaller claim payouts since the state is going to be paying for part of the disability coverage there. The voluntary LTD that employees pay for is actually also running quite well at a 68% loss ratio. And the standard did offer some rate relief on the last renewal there. The employer paid LTD is the one plan that is trickling up a little bit there. So you'll see it's running at 91%. And while the standard did offer a rate hold, when I looked at your experience, which in the appendix of your packet, if you want to look, take a bit of a deeper dive, there are some more details in there. But from 10/1/22 to this past June, the loss ratio was quite high. And while there weren't a huge number of claims, there was about 2.7 million paid out in that time frame, with another 2.5% in claim reserves. So that's money that the standard has to put aside when a claim transitions to LTD to make sure they can pay out that claim. And typically, most carriers probably wouldn't have offered a rate hold there. I do think they slightly discounted the reserves to be able to pass on a rate hold to OEB. But again, something I just kind of want to keep an eye on to make sure that, we don't trickle up into higher 90%, because the next renewal, they may not be able to hold the rates. So I want to pause there and see if there's any questions.
Yeah, Amanda, I have a question. So
Yeah.
is there any rational explanation of why employer paid LTD would have a higher loss ratio, higher usage than voluntary?
So, typically you see it in reverse because, there's a bigger pool of employees in the employer paid LTD, and you typically see lower utilization. On the employer paid LTD, there were some higher dollar claims that paid out that really drove up that utilization and loss ratio. Again, those high reserves. And there were quite a bit of claims closed. So that's telling me that you are having a decent amount of claims move into LTD, but they might be closing really quickly, or they might not be getting approved on LTD because they're returning to work sooner there. But yeah, you're kind of spot on. We typically see these numbers with the loss ratio on voluntary versus employer paid flipped.
So, Amanda, in terms of what we're seeing, the only one that you've really highlighted as potential problems and rates going up is that last one, the employer paid LTD.
Mm-hmm.
None of the other ones I heard you say, watch out, you may be seeing rate increases. Is that a fair comment?
Yep. Yes, I would agree. The basic life is running at 88%, but it's been very stable over the life of the plan. So I'm not concerned about that one. It's not very high dollar payouts either. And to add a little more context on LTD, I've seen a lot of employer plans trickle up a bit in the post-pandemic world with experience as well for a couple reasons. I think we also saw a lot of leave activity on the short-term side and FMLA during the pandemic. But what happened is a lot of employees delayed care. So maybe they were diagnosed a little bit later, which kept them out of work longer. And we're seeing, overall in the market, more claims go to LTD. And I think every carrier's kind of hoping that in the next few years, we see LTD claims trickle back down. We just haven't seen that yet. But like I said, it's something I want to monitor. I worked with our account exec over at the standard to get some more information. So that way in the future, we can look at trends with diagnoses on those LTD claims if it does get any higher. But the hope is that it does trickle back down. And I have some information in the benchmarking. There are some potential plan design changes we could look at. One with the duration that may help if we do see those claims continue to trend up as well. All right. If you'd like to move on to the benchmarking slides, we can chat through those. Okay. So overall, you really offer a great variety of disability plans specifically. So both employer and employee paid STD have varying benefit amounts from 60 to 70%. And then the employer paid LTD and employee paid LTD, you offer varying benefit amounts as well from 50 to 60%. And overall, your plans are at benchmark to what we see from employers of similar size and geographic location. And the one area of opportunity that could potentially help that LTD experience is the duration on your STD plan is only 90 days, which means there's only a 90-day elimination period on that LTD. So that's a little over 12 weeks. So with that shorter duration, there's the potential to have more claims trickle into LTD. And for example, paid leave Oregon, that's a 12-week duration, but maternity claims under paid leave Oregon could potentially get 14 weeks of benefits, which would take those claims into LTD for you all. If you look at, for example, a maternity claim, typically if it's a C-section, a carrier is going to approve that 8 weeks from the date of delivery. So that's already 8 of your about 12 and a half weeks right there. If they have, preeclampsia or any complications before, they may need STD before they give birth. And then if there's any complications afterwards or postpartum depression, those claims could potentially trickle into LTD, which could drive up your utilization. Another great new benefit for your employees is Paid Leave Oregon that went live. It was effective 9/3 of this year, and that is a paid benefit for their own medical condition as well as family leave. So employees now have access to that state program, which will actually pay them for child bonding or care for a family member. They also extend that benefit to employees experiencing domestic violence, harassment, or sexual assault. So that's something that I know there's an employer cost as you have to contribute to the plan, but significantly cheaper than fully paying out bonding time to all your employees. So it's really great that they have access to that now. If you'd like to move on to the next slide. Thank you. So this is just a summary where our absence and disability benchmarking comes from. So Mercer completes a survey that we call our ADM survey, or our Absence and Disability Management Survey. And this is the 12th survey we've done on this topic. We began them in the year 2000. Essentially, this survey goes out and it just gets into the nitty-gritty of disability and leave trends among our clients here. So we used 3 benchmarking cuts in this survey. Our West region, employers with over 10,000 employees, and then all respondents from the survey. If you'd like to go to the next slide, please. So for short-term disability, all of your plans have a 7-day elimination period, and all 3 data cuts, that is the most common. So I would not recommend any changes there. As far as the benefit goes, again, you offer a 60%, 66 2/3, and a 70% benefit. And among all 3 benchmarking cuts, the most common benefit is a uniform percentage that pays less than 100%. And the median benefit offered is 60% across all cuts. So OEBB's STD plan benefit at percentage is actually at benchmark, or in some cases a little bit higher, which is great. The weekly maximum is at 1,500, slightly below benchmark, but not a real concern there. It's not that much lower when you break it out across the year there. So again, no real concerns there. Again, coming to that duration at 90 days. You'll see all 3 benchmark cuts. The most common is 180 days. And a big reason is because, preventing those claims from going into LTD. Because even if they don't pay out, it can still potentially impact your experience for a couple reasons. One, those reserves are really high. Waiver of premium on life insurance comes into play, which actually can impact your life experience too. So that is one thing that I would recommend maybe we take a look at in the future. Again, I would want to look at data from, how your utilization looks once Paid Leave Oregon has been into effect for a bit. But that's the biggest opportunity, I think, to make any changes to these plans. As far
Amanda,
as, yeah.
When you talk about, though, moving it from short-term disability to long-term disability, that 90 to 180 days, how is it different? Is it that there's greater liability in the long term than in the short term? if it's dollars paid out, does it matter whether or not it's in the short term versus long term? I don't
Yeah.
understand this well enough to be able to understand it.
Yeah, good question. So the way the plan's set up today, there is more liability and more dollars at risk in that LTD plan. So with the LTD running a little bit high right now, extending the time on STD would help lower that LTD experience. You'd have less claims making it to LTD, which I know would shift a little bit of risk to STD. But with the Oregon benefit, what happens is that Oregon is going to pay out the bulk of the STD benefit. It's going to be an offset to what the company plan provides. So we should continue to see the STD dollars paid out decrease in the next year because of the new Oregon paid medical leave that was enacted. So it does kind of shift the liability, but as far as how your plans are running, I think it is something worth exploring. The other item to think about is it can tend to be a little bit of a better employee experience having a longer STD duration, because once you get to long-term disability, the definition of disability actually changes a little bit. So in STD, they're really only looking, can this employee return to work doing the job that they are in today? So if someone is a teacher, they're only going to evaluate them on STD if they can go back to being a teacher. On LTD, the definition gets a little bit stricter, where there's going to be an earnings test. So if they try to get back to work part-time in STD and they earn too much, they may get denied LTD altogether. You hit a point in LTD where it goes from looking at if they can do their own occupation to being able to work in any occupation.
Okay.
That's at the 2-year mark, which is, there's a good chance you're probably not keeping employees on staff that long if they've not been at work for 2 years. But at that point, they're trying to get employees back to work doing anything. And it's really to the employee's benefit to maximize that own occupation period as long as possible, because the carrier is going to work with them and pull in their vocational resources at the 2-year mark and really get a lot tougher on approving or extending LTD at that point.
Thank you. That helps
Yeah.
me understand.
Yeah. Any other questions on that before I move on? Okay, so we'll look at the contribution. Again, you offer a mix of some voluntary employee paid plans as well as employer paid. We do see more employer paid plans on STD, but there is certainly a split. We see some all employee paid plans as well as core buy-up plans, or a split between employers and employees. Funding being fully insured, you'll see that, we're looking at around 30 to 40% across all 3 data cuts here being fully insured. And if you combine the ASO with check cutting and advised to pay, those would be self-insured, and between 50 to 60% in all 3 data cuts are self-insured. But I wouldn't recommend that for OEB. With your structure and the multiple different plans, self-insuring it and having to deal with offsetting what Oregon's paying and running it through payroll, I think administratively would be a headache for OEB. So I would not recommend moving it to self-insured. I think fully insured makes perfect sense for your population. So before I go on to LTD, any questions on STD benchmarking? Okay, you can move on to the next slide, please. Okay, on LTD, again, coming back to that elimination period. So your duration on STD is going to match your elimination on the LTD, which it does. But again, that's just that opportunity to potentially look at shifting some of that liability off of the LTD if it continues to run a little high in the loss ratio. The benefit will vary on LTD among both employer and employee paid plans between 50 and the 66 2/3%. So all 3 data cuts, 60% is most common. So your plans are right in line with that. The monthly maximum, there is a lot of variance in these plans here. And if you see 10,000 is pretty common across the board. So LTD is going to be approved and paid out on a monthly basis. And you have plans that range from $8,000 monthly maximum down to $2,000. Some employers, kind of all have different philosophies on LTD. Some look at it that, they're going to be probably separating employment at some point. If you make it to LTD, they're not as concerned with providing a richer benefit there. But one thing you could look at, and I would be hesitant to do it soon just because, again, the employer paid is the one that's running a little bit higher. But, if you wanted to bring that closer to benchmark and cut down on employer costs, we could look at an employer paid core benefit with an employee buy-up. So while your benefit percentages are right in line with benchmark, you could keep those the same and say that, there's an employer paid $2,000 maximum, but you can buy up to an employer paid $6,000 maximum if that's something you wanted to look at in the future. But if we made that change sooner rather than later, that would probably contribute to larger claim payouts. Potentially, there will be more premium coming in, but there's always a good chance that those who decide to participate in a buy-up or a voluntary program are doing so because they plan to utilize that benefit. So sometimes, it doesn't play out in the experience and it could drive that loss ratio up. So something to think about, but not something I would recommend moving forward with just yet.
Amanda, I have two questions.
Yeah.
One, the lower monthly maximum, is there a connection between that and it being a 90-day rather than 180 days start?
No, so that wouldn't have any impact on it because, the 90 days is the elimination period. So LTD will kick in as soon as STD ends if they were to remain out of work that full duration. We typically don't see the maximum vary with the elimination period. So if an employee that is in the $2,000 maximum plan were to go out of work and make it to LTD, even if they're in a 66 2/3 plan, so your richest LTD plan, if their benefit would be $8,000 a month at that percentage, they're going to cap it down to that $2,000 because it's the maximum. And it's going to pay out each month that way. So the elimination period wouldn't have any bearing on that.
What I meant was, is the lower monthly maximum for OEB is one of the explanations comparing it to the West region is that the West region has 180 days rather than 90 days. Or are they two different? Are they interconnected or are they not?
Not really very interconnected.
And then the second question, if you have a employee buy-up, how does that affect the taxability of the benefit?
Yeah, that's a really good question. So what carriers can do is if the core benefit is employer paid, that would be a taxable benefit to the employees because the employer's paying that premium. The buy-up portion then could actually pass tax-free to employees because they are paying that portion of the premium. Essentially what the carrier would do is confirm the contribution percentages there, and they would handle taxing the benefit appropriately. It's not uncommon, and typically LTD carriers are producing W-2s for the employees for what they were paid on long-term disability. So not something that OEB would need to try to wrap their head around or figure out how to process that at tax time. It's very common, especially because employees can be on LTD, until their 60s and they're long separated from their employer. But yeah, it would be a split contribution. Basically on disability payments, the government just wants their cut. They don't care if it's post-tax contributions or taxing the benefit.
Thanks.
Yeah. Any other questions on like the monthly maximum or anything else I've shared so far?
Amanda, it looks like there are several people
Yeah.
with their hands up, but I don't know if they're still up.
Yeah, hey, this is David Scarce at the Standard. I just wanted to give a quick synopsis on those maximum benefits. The reason that we have them varied from $2,000 up to $8,000 was when the plan was written back in 2009. There were actuarial equivalent requirements at that time, and so that's why you see all those varying plan maximums. So, kind of with the short-term disability plans over time, we have slowly moved, whittled those plans down to now just offering 9 plans. On the long-term disability side, we are offering 26 different LTD plans with varying maximums because they had to meet an actuarial equivalent at the time back in 2009 when OEB was being formed. So, we are certainly more than open to any discussions around wanting to change any of those maximums based on current times and what we would, what we'd like to see from a benchmarking perspective. But just from a historic perspective, that's why those maximums are the way they are.
Thank you, David.
Yeah.
Okay. Looking at the contribution, again, you've got the mix of voluntary and employer paid plans. And if you look here, the West region, we are seeing significantly more employer paid plans. But looking especially at the 10,000 plus benchmarking cut here, the most common is actually a core with a buy-up. And again, that buy-up can be in regard to the percentage or the plan maximum. So it's definitely something that I'm seeing a lot more employers consider now. With the rising costs in healthcare and prescription drug coverage, there's not always enough room in the budget to increase benefits on the disability side. But typically, if you're at least offering a core benefit, you're right in line with other large employers. The funding, so your LTD is fully insured, and you'll see below that is by far and away most common. Very, very rare for employers to take on the liability to self-fund an LTD plan there. Any questions on long-term disability? Okay, if you want to move on to the next slide. Okay. Just wanted to offer some information on paid parental leave now that your employees have access to it through the Oregon PFML program. But as you can see, it's something that's been a trend in this industry. And in 2015 is when it really began to pick up steam. In our last survey in 2021, we did see it about 60% of employers are now offering it. So again, really great benefit that your employees now have access to. And certainly makes a big difference in your benefit offering to those employees. You can move on to the next slide. So parental bonding leave that's offered through the Oregon program, that's going to run at the same time with any paid or unpaid state mandated benefits. So it's going to run at the same time as FMLA. So employees aren't necessarily getting more time away from work. They may be more willing to take it now because it's paid. But again, it's going to run at the same time and utilize and use up that FMLA entitlement if they are eligible. And again, bonding time, we really want to use that just for truly bonding with a new child, whether that's through birth, adoption, or fostering. And the Oregon program does accomplish that for you. Again, provided some benchmarking here just to see where you lie with other employers, in similar demographics. So the first box is bonding care for a birth parent. So for offering paid leave, we're looking at about 61 to 68%. And then bonding care for non-birth parents, again, 61 to 67%. So really great benefit that you've been able to add for your employees this year. Again, it's something I definitely want to look at, how well it's being utilized there. I think it might be quite a big change internally. In the past, we didn't see as many non-birth parents utilize their job protected FMLA leave to bond with a new child if it wasn't paid. Saw a lot of birth mothers do it, but I think it's kind of opened the door to make it more acceptable for men and non-birth parents, like adoptive parents and foster parents, to really take that important time to bond with a new child. So that's an exciting new perk for your employees. So any questions on bonding leave? Any questions on paid leave Oregon that I can help with either? I know that's probably brand new for a lot of you on this call as well. All right, perfect. Okay, John, I will pass it back to you. That is the wrap up on the disability.
Actually, John, you were
Good.
incorrect. You were incorrect when you said that your appendix was the best for sleep. I think going through all the details of all the different, it seemed 100 in the disability. I mean,
If you can't
Amanda, it was
sleep
a great
tonight,
present. It was a great presentation. Don't
if you
get me
can't
wrong.
sleep tonight, dig into that LTD utilization. There is plenty of it.
Yeah, yeah. Try to figure out the differences.
That's why I summarized it in just LTD as a
It
whole.
was great. It was perfect. It was perfect.
You know,
Thank
next year, if you want to talk through all 26 plans, just let me know. This meeting might have to go till 8 o'clock at night, but we can pivot if you want to review it.
Yeah, I'd rather put a needle in my eye. Okay, let's move on.
All right, thank you.
Thank you so much. Okay, so we are about 10 minutes ahead of schedule. And our next John, did you have any wrap up for the benchmarking stuff?
No,
or do we
no,
just
that's
move on
it.
to
Nope.
Christy now?
Thank you, Tom. Yeah, we're ready to move on to the next piece.
Okay. Thank you. Great. Okay. So what we now have is a presentation on health equity, the work group's update to the board. And Christy Ewing is going to give it to us, I think.
I am here. Hello, everybody.
Great. Hello.
Awesome. So I'm going to go over our some updates from the health equity work group and what we've been up to. And so really, as we've been diving in and looking at the needs of OEB members, as we all know, there's these different populations within OEB, and we know that, different members have different needs. And so this slide is just kind of talking to those and recognizing what the population of OEB is. And so if we move to the next slide, as we look at the population of OEB, and really wanting to get a starting point of what the benefit coverage is when we look at it from an equity lens. And sorry, if we move to the next slide, I don't think mine's moving. Great, thank you. And so I think we've seen this slide before, but just really wanted to highlight what a diverse group that OEB population is, and that, again, recognizing that each member has different needs depending on, if they live in a rural area versus urban, what stage of life they're in, if they're LGBTQ+, if you're a woman, veteran, so just very differing needs. And so what we did is we did what was called a DEI plan design review. And this review basically looked at the benefit coverages through the SPDs for both of the medical carriers, kind of through the lens of these different population cohorts. And so if we move to the next slide, what the DEI plan design review really highlighted was a couple areas of high priority focus, and specifically for pregnancy-related care and treatment and inclusive family planning. A couple things within the DEI plan design review, and I'll go over this, I have a few slides that goes a little bit more into depth, is just recognizing that within the DEI plan design review that we identified some short-term actions that could possibly be taken this year through the renewal letter process, and then also some longer-term action items that we will continue to have kind of on our longer-term strategy. And again, the DEI plan design review did a very in-depth look through the lens of these different populations and how different benefit coverages would meet the needs of different populations. So if we move to the next slide, a couple great strengths that the DEI plan design review showed for OEB's benefit coverages is that it's really inclusive of all populations. So recognizing that really that wider inclusiveness for different families and what different families look like. Also, there's some really strong behavioral health coverage specific to mental health and substance use disorder. Just two little things to call out that were highlighted as good strengths is that, you know, inpatient and outpatient behavioral health treatment really, you know, is covered without these restrictive limits that we see sometimes in other plans. And then also treatments with suicide attempts is covered, which I know seems kind of seems odd that something might not be covered, but we do see this sometimes, that there are certain exclusions from plans on different, you know, treatments if somebody has had an attempted suicide. And then lastly, some strong coverage for people with disabilities. And so really there's good coverage for medically necessary hearing and vision, and then also good coverage for prosthetics and durable medical equipment. If we move to the next slide, this is the slide that kind of talks about some of the opportunities. And I know we've heard before, Tom, you brought up, you know, IVF, which came up as one of those opportunities. And so really looking at short-term opportunities within that pregnancy-related care and treatment is, we know that doula services right now are being discussed at CIAO, and that will be coming up in the next couple months to the board. Talking about, so coverage for alternative forms of birthing support, such as birthing centers and home births for low-risk pregnancies. And that kind of goes in tandem with coverage for midwives, covering certified midwives and certified professional midwives. Oftentimes at birthing centers or even with home births, that it oftentimes can be a certified midwife or certified professional midwife that is performing those births. And right now, MOTA did state that they covered midwives and certified professional midwives as long as they're licensed or certified, but Kaiser does not. And then the last thing under the pregnancy-related care and treatment was something for medically necessary genetic screening during pregnancy. And so just bringing that in alignment for both the plans so that it's the same. And I'm gonna pause to see if there's any questions on that topic. All right. And so then the other focus topic that came up as an opportunity was inclusive family planning. And so the areas here, so the first one here is the removing of the requirement of a diagnosis of infertility. And so currently the diagnosis requirement of infertility means that you have to have intercourse for 12 months trying to get pregnant. So that does not apply to you know, a single person who is trying to you know, get pregnant as a single parent, or to same-sex couples. And so removing that requirement of that diagnosis of infertility. The second thing here is considering coverage for the assisted reproductive technologies, which does include that IVF. And then lastly is aligning plans to cover medically necessary cryopreservation. And so that's with eggs. And right now there's some coverage that if cancer, so some cryopreservation is covered if somebody has cancer diagnosis, but not in some other areas that we would recommend that that would be added as coverage. And so again, these are short-term opportunities. Yeah.
Yeah, Christy, how do you and Mercer view that you'll be bringing these issues forward for discussion?
Thanks, Tom. A great question. I think really from today is that we would just like to hear from the board or a thumbs up if you would like us to include these items in the renewal letters. And that was kind of how we would have it. You know, first we would include them in the renewal letters to ask the carriers, you know, if they can cover it, and then also the financial impact of covering it, of these different items or making these changes. And then it would come before the board as part of that renewal letters process in the next couple months.
Okay. Do you think that it should go to CIAO for vetting before coming to the board, or should it be discussed at the board level? Kirsten, I
Kirsten,
see
I
you
know.
just put your
Yeah.
hand up.
Yeah, I'll attempt to be understood. I think when we talked about this at CL planning, the doula services are coming through their normal
Right.
process. I think the consensus was because there aren't any clinical concerns with IVF, it could go straight to the board in December. So that was our plan at this point.
Okay, thank you. And the other issues, cryoprecipitation, I'm sorry, cryopreservation, and the issues around midwifery coverage.
I think those as well. There's not necessarily a clinical component to them. You know, there's some just disparity between the plans of what's covered. And so that's where we would like to just, you know, bring some alignment of the plans and include those in the renewal letters to see, you know, what kind of the impact would be of including those.
Yeah,
to bring on
there's you know, having lived in the Kaiser system for years, the issue around delivery and the system for coverage of labor and delivery is such that I think the board is not probably the right place to have that conversation. So I would request, because I want to get I want the plans to be able to discuss it, and I don't think the board is probably the right first place for those to go. So definitely the issue, again, removing the requirement for diagnosis of infertility. The question there is if it is a couple, if the couple in question is male and female, are you looking at eliminating the diagnosis for infertility for that couple? It's pretty clear for the examples, again, the single parent by choice and same-sex couple, that the requirement, as you described, just doesn't make sense. But I think these are ones that I would like to have vetted at CL before they come directly to the board. Obviously, the doula coverage is what is coming through CL, and having IVF come is fine too, coming directly to the board. Go ahead, Kirsten.
I just wanted to clarify what we mean by come directly before the board. The renewal process, and I know there are some new folks on this call that weren't on the morning call at CL. I apologize, I'm sick, so I sound froggy. The renewal letter is the process that kicks off, you know, hey, Kaiser, hey, Moda, this is what we're thinking about. You go think about it also, so we can collaborate in the spring. This, when we mean bring in front of the board in December, what we mean is that we're just thinking about the renewal letter at this point and alerting to the carriers to the fact that, hey, these are things we're exploring. And then we still have January, February, and March to work with the carriers to understand all of the details, and then the board would vote on these in April of next year. So it's really just, hey, do we want to you know, get the carriers in on this process and collaborate with them more over the next few months.
Okay, that makes sense. I appreciate your explanation there. So there still would be, again, there are the issues that are there are relatively complex medical or health delivery issues that I would like that aspect of it, if the board decides to include it in the renewal letter, they'll need to be discussed. That's what I'm saying, and I would like to have those issues vetted at CL as compared to coming just to the board. in that January, February, and March period.
Yeah, I think we're on the same page for sure.
Okay, great. Thank you. Now I saw a couple of hands. I saw both Glenn and I saw Enrique. So Glenn, I think you were first.
Yeah, actually, Kirsten kind of answered my
Okay,
my point.
Okay, good. And Enrique.
Yes, thank you, Chair. My question is for Kirsten. Maybe I misheard you, but I understand that you said that in looking at the literature, we're trying to add home deliveries to the insurance coverage, or is that what you were thinking?
As something to consider, yes. I mean, adding coverage for these alternative birthing supports is an approach that in one way can meet a lot of people's cultural needs of wanting to have a birth at home, again, only for low risk pregnancies. And again, it's where typically a certified midwife or certified professional midwife is going to be the provider of that birth. So it's just, yes, okay. It's an alternative form. Mm-hmm.
Okay. I guess my concern is that we have seen research indicate that African American and the Hispanic community death rate on birth is higher than the other racial groups. But my concern is that we might not have all the healthcare or critical care and complications, and you don't know that until the very moment at times at birth. So I guess for my own knowledge, maybe I would like to see some data how Oregon has improved on this matter, and because what I would like to avoid is to have further complications at birth for people of color, just because they have a certified midwife or a doctor, but yet we're not addressing the main problem. So I'm with Tom, I guess, that there should be a further study on that, but that's all. I rather personally.
I appreciate what you're saying, Enrique. We will get, and that's the reason that I wanted there to be a chance for the delivery system to get at, because there is that the as you're describing, the medical risks associated with some of these other issues, and low risk and high risk, and so we will. I think it's very appropriate for the health equity work group to bring these issues forward, and we will apply the due diligence in the first quarter of 2024 to see how we want to move forward with these.
Thank you. And also, just to add, I know last time I asked questions about equity on our policies, how we're implementing that, and I see that you're addressing it and how you open up your discussion today. So thank you to the chair and the staff for addressing and answering my question from the previous meeting. And I support the IBF and other parts of the conversation. Thank you.
Great, thank you. Okay, Christy, you're back on.
Yeah. All right. Well, thank you. I appreciate the dialogue, and yes, and I have lots of literature, so happy to share as well as we dive into that further in CL. And so, my last point just on this slide is just recognizing, that there's some short-term opportunities, but then there's also, these are part of a broader long-term strategy. And so if we move to the next slide, the other thing that I wanted to share today was about gender affirming care. Something that I just want to, that we are working with OHA staff on is, so House Bill 2002 passed in June, and this is really addressing gender affirming care as part of it. There's another part of the bill as well, but the gender affirming care part really states that the state cannot deny or limit gender affirming care treatment that is medically necessary as determined by the provider. The provider can be a physical or behavioral health care provider, and then also needs to be prescribed in accordance with accepted standards of care. Additionally, there is some language in the bill regarding cosmetic services, that there is a list of some cosmetic services that cannot be denied as part of gender affirming treatment. And then there's also a part of the bill that is addressing network adequacy of gender affirming care providers. Along with House Bill 22002, there is also something called WPATH 8. This is the World Association for Transgender Health. And really they are setting this, one of the highest standards of care for gender affirming treatments. I have a little historical on here. They've been in place for quite a while, since 1979. One thing to call out is their last standards of care, which is version 7, was about 10 years ago. So just in 2022, I think it was October, they came out with their standards of care 8. And these are evidence-based, standards. Really it has a multidisciplinary team that has come together to set these standards. So what does this mean for OEB's members is that there's, with House Bill 2002, right now, there is this the work going on between OHA staff with OHP, and really, I think this, looking at House Bill 2002 and how to align and really figure out within the bill, what does it mean? There's not a whole lot of concise language, and there's not a specified standards of care in the House bill. However, it looks like there's going to be possible alignment with the WPATH 8 standards of care, yet to be determined, but there is the possibility that that exists. Glenn, you have your hand up.
Yeah, I would just add that it's more than likely that WPATH 8 is going to be used as the standard of care that plans will be evaluated on by DCBS, which will do a market scan in 2026. Also, they're going to be going into in December rulemaking to provide more detail to this bill. But there is right now a work group within OHA, which OEB and PEB participate on, that is looking to really kind of move this forward and not totally wait for DCBS on that. The operative date is for OEB would be in October 1st, 2024. For this, but yeah, we are working with other OHA staff to try and move this forward, and an important part of that is actually, excuse me, Mercer has completed a review of all both PEB and OEB carriers and the benefits that they currently offer against WPATH version 8. To see whether we have any, to see what kind of alignment we have, or if we have any, needs to change in regards to coverage.
Glenn, it'd be great to make sure that that both Kaiser Permanente and Moda Health have WPATH 8. They may already have it in their systems to look at and evaluate, but
they do actually.
Okay, fine. Perfect.
And
you're already working with them. That's great.
Yeah, we're already working with them. All
Okay.
three carriers, and
Super.
all three indicate that they either base their protocol on or use WPATH 8.
Okay, so this is not going to be a huge issue for us. It sounds like.
No, not specifically on
Except
coverage.
to understand the potential costs associated with it, but it's
well,
yeah,
and that will be. We're going to try and make sure that gets wrapped into the renewal. But
okay.
the areas that where we may see some slight changes, I think, is in regards to any limits that are currently in the benefits, and then the carriers, of course, are going to be evaluated based on network adequacy.
Right. Okay. Enrique, I saw your hand up.
Yeah, when I was reading this through the literature, on our packet. I have some questions on maybe. I hope this is not an action item for today. I just need to know more background and where the Mercer staff or our staff are in this.
It's not an action item for today. This is just informational.
Okay, thank
Sure.
you. So I'll just take another
Yeah.
read and send you some questions, Tom, and
Yeah.
get the answers. Thank you.
Super.
All
Okay.
right. Glenn, you did great foreshadowing to my next slide, which is about the work that Mercer is doing. So in October, we started this transgender, gender diverse benefit review. It's something that Mercer has done the past several years, and we've been doing more of them now with the update to the Standards of Care 8. And so again, we've really been working, our health equity team was working really closely with Glenn and Sharna, and also with the carriers as they completed this review, having those conversations, really getting a good idea of what is currently in place, and talking through WPATH 8 standards of care, and then also kind of incorporating House Bill 2002 as much as we knew, obviously without the rulemaking process being completed. So this has actually been completed. It's like hot off the press, and I think we'll be doing a review of it later this week. So this is just a great alignment, as Glenn said, for us to really try to get ahead of this and be able to push it forward. So
Great.
all right, and then I think I might have one more. Yes, awesome. And so just finally, just kind of wanted to talk about, kind of what a health equity strategy for OEB, the items we've talked about that we're currently doing is, kind of that shift left. And so, so important, we've talked about this before, is taking the real D and demographic data, to identify gaps in screening and care, and making action plans, once we identify those gaps, really making action plans with our carrier partners on how to decrease those gaps. Also improving capturing of those social determinant health Z codes. And so these are, new Z codes that were put into place that providers can use to code different social determinants of health needs. It's an easier way to kind of capture the needs of members and be able to track them and connect them to the resources, and then follow up to make sure they've gotten connected to resources. Also a great way to do some additional reporting to identify gaps and where different services are needed. As far as education goes, really in a strategy is obviously having really good member-facing communication on equity-focused benefits. And then once the gender affirming care and House Bill 2002 get, really decided upon on exactly what that coverage is going to be for the October of 2024, really communicating about what those gender affirming care benefits are. Quality and efficiency and the 3.4% cap, recognizing that a lot of what we're doing in equity actually really supports quality. In many ways, quality can't be had for all without equity as an essential component to that. So recognizing that higher quality care will come when everybody's cultural and linguistic needs are met. Again, removing that requirement of infertility diagnosis, and then exploring IVF and other forms of art therapy. And then in the 3.4% cap, there are some opportunities here to either be cost neutral in some of these equity coverages, or have higher quality care that's being offered.
Okay.
All right. Thanks, Tom.
Thank you very much, Christy.
My pleasure.
Okay, folks, that wraps up the first half of our session. We have a 10-minute break. I have it at 2:26. Let's start up again at 2:36. We have still a lot of items to go through, and some of them are pretty complex. So we'll break now and gather again in 10 minutes. Hello, Georgianne.
Hi, Tom.
So we'll get started in a couple minutes.
Okay.
Okay, I have it at 2:36. In terms of board member presence, I'm just looking, I've seen that Bonnie has joined us and Susan Miller has joined us, and I know Robert Young has needed to drop off at 2:30. So we still have 1, 2, 3, 4, 5, 6, 7 board members. We have a quorum and we're able to keep moving forward and doing business. So with that, we're going to be hearing from Georgianne on the OEB Advisory Group report. Georgianne, you're on.
Okay, thanks, Tom. Good afternoon. I want to give a quick overview of some of the things I've been working on through the summer. I was not able to join you in the September meeting. Fortunately, I got sick the week of the meeting. So I wanted to kind of wrap up, share with you some of the thoughts and comments that I ran into this summer, and then talk a little bit about the OEB Advisory Group and a recent project that we've been working on with them called the Deep Dive. So activities, I spent some time this summer with OASBO Group, really talking about the 3.4% target threshold and how that's actually playing out with the different entities and trying to understand that. And we've been looking at that quite a bit recently to understand how that 3.4 rolls out into the entities. So we talked about that, and we'll talk about that a little bit more here in a few minutes. I was able to attend a number of open enrollment meetings around the state, in the rural areas as well as in the urban areas. And rural areas, we're still receiving the feedback that there's a perception of lack of options. We understand certainly that one of them is they don't have access to the Kaiser benefits, but we also think there may be some additional things going on there that might be impacting our rural members, and we're starting to look into that a little bit with more detail. In conversations with teachers, employees, staff, districts, we got a very, very strong feedback. There's an overall very positive feeling about OEB, about the benefit offerings. There is good choice or quality benefits. I did hear great feedback about the OEB staff as well as the carrier teams. That when people have questions, they're able to get answers. They may not always agree with answers, but they like the fact that they're hearing responses and they are feeling that they're being heard, which is great. I did ask a little bit more about the EAP in different areas because we certainly have had feedback on that, and that's still kind of iffy. There's still some insecurities around if the EAP will really be there for them. One of the things that we heard out and about is that the districts, some of them do offer HRAs, health reimbursement arrangements. They have health savings accounts. They have flexible spending accounts. And these are the types of accounts that are entered into contract district by district, because as you know, OEB does not have access to payroll. and those are payroll functions. So they have a variety of vendors that they are using. And I heard it in a number of places saying it would be really interesting and really nice if perhaps OEB could come up, if OEB would endorse a vendor for HRA, FSA, HSA, get us some really great pricing and some great service, and give us a preferred vendor for those services. So that was good feedback, something that we had not heard previously. So that was good to hear that that's something they'd like to see. Just a quick update on enrollment. Effective October 1, we did add the Corvallis School District teachers, about 900 employees. So we've got a number of new members. And on January 1, Alliance Charter Academy, it's a smaller charter school in Oregon City. They'll be joining on January 1. They've got about 30 benefit employees. So once members are on, we'll see some additional growth there in January. So always nice to see some new players. And you can go to the next slide. Thanks. So I talked a little bit about the advisory group and project they're working on. This summer, we worked on a deep dive project. And again, looking at this 3.4% target and the impact on the various entities and how that plays out. So we took 4 districts. We had 4 that volunteered to work with us, which was very much appreciated. We did a 3-year look back at each of them. We looked at contributions, what plan offerings they have, what the rating structure, whether they're composite or tiered. Do they have opt-out provisions? Can they get pay in lieu of selecting benefits? We put all the information into spreadsheets and started kind of looking at it, pulling together some ideas. And the first thing that we came across is nomenclature. There's a lot of things out there. We hear per employee per month. And the first thing that comes up with per employee per month is employee. When in reality, when we're looking at these numbers, it's actually subscribers. So not everybody enrolls in the benefits. So for a nomenclature, and just to all get on the same page, we want to start using the term per subscriber per month. The per subscriber per month cost is the measurement that after looking at all of the data in big form, once we break it down to the per subscriber per month cost, we're able to pull together a clearer picture of how an entity is performing next to OEB overall. It takes out a lot of the wiggles in the numbers and it gets it down to one thing. So our definition of per subscriber per month is taking the total premium that an entity pays for medical, dental, vision. So the total premium for those 3 lines of coverage, taking that total and dividing it by the number of subscribers on the medical plan. Because there can be some varying enrollment in dental and vision, the way to keep it as aligned as possible is to use the total premium and divide it by the medical head count. We do that with the OEB totals overall. So OEB, the giant number of premium, divide it by the number of medical subscribers, and we come up with a per subscriber per month for OEB overall. And then we do it on an entity basis and compare them. What this pointed out pretty quickly is that when you look at the OEB experience overall, and you look at all the plan options, the enrollment between the plans is much more spread out than we found in the first 4 entities that we've been looking at in detail. For example, OEB book overall, MOTA Plan 1, 19% of the enrollment, MOTA Plan 2, it's like 22%. There's a pretty strong percentage in each one of the plans 1 through 7. Knowing that Plan 1, Plan 2, Plan 3, they are more expensive, that premium is higher. When we look at the entities, the ones that we looked at, these 4 original ones, their enrollment was more than 70% of the enrollment was in Plan 1 for both Kaiser and MODA. So even with the additional options, the contributions, and some of the different strategies, in the first 4 we've looked at, that enrollment is really high in those really expensive plans. So what ends up happening in that case is that those entities will see, they may see increases that are greater than 3.4% just by virtue of the enrollment. It's the way that enrollment is falling out. That's what's driving how this 3.4 goes through to the entities. Because remember, the 3.4 is all of the coverages combined. You pay, vision went down a little bit, medical went up a little bit, boom, boom, we get to 3.4. So if you have districts that have enrollment that varies from the OEB overall enrollment, you will not have the exact 3.4%. So one of the first little 2 things, one, nomenclature, 2, really starting to get a feel for how this happens with this enrollment and how that falls out. So where does that take us? Next slide, please. So first of all, we talked about this already, per subscriber per month for nomenclature, I think is clearer, will help people make sure we're on the same page. The other thing that we discovered in talking with these 4 entities was how soon in the process are they hearing about an expected renewal increase. The board has a pretty good idea of what that's going to look like in around March. And we need to start getting earlier notification out to them. So that's something that we'll take on as the OEB staff to make sure that we are communicating sooner than later with the entities about what the board's looking at through that renewal process. So they kind of get a feeling as they're going in and talking with their folks about where we might be headed with an increase year over year. The other request was, just making sure there's continues to be lots of communication. We're told a lot of times at OEB that we communicate like crazy in a lot of different ways, but we always find that there's some little areas that we can improve. So we're going to start doing a specific summary for some of the associations that will talk a little bit in more detail, some of the board discussions and decisions that impact them more directly, things that will speak to them more directly than just kind of the big picture. So we'll take that on so they can really feel, because as we know, everybody's busy, and for them to have the time to, 1, attend a board meeting is not realistic, and 2, to go through all of the documentation is a lot. So we will try to pare down some of that communication to make it easier for those associations to have a better understanding of exactly where the board is at throughout the process of renewal and looking at the different options. In conjunction with our Mercer partners, we're going to roll this out to some further entities. So as I said, we started with 4. 1 was remote. The rest of them were local. So we're going to go up. The next one's going to be, we're going to take 4 rural districts. We'll do 2 large ones and 2 small ones. We're going to take them through the same process and really want to look at, in the rural areas, are the levers that they're pulling, are they different than what we're seeing in the urban areas? I mean, are they on composite and versus tiered? Are they, what strategies are they doing that may be different than urban that might be impacting how their employees are enrolling? And what plans are they offering? Are they offering as full a choice as they can? So I want to continue to look at that again, really wanting to understand this lack of choice, knowing that we can't, Kaiser's not going to be there, but is it really around that feeling of loss, or is it around they don't feel that they have access to all the options that are there, perhaps because of the way that it's financially arranged? So again, just really trying to understand in more detail about what's going on. So that's what I've been working on. Any questions? You can go to the next slide. Any questions or comments for me? I must
Sounds
be really
great,
good, Tom.
Jen. No, you are. And, it's very helpful to have the filling the role that you are. When you talk about direct communication, the fact that that OEB has been able to get someone of your capacity to be able to go out and work directly with, as you say, communication is kind of the key, are the key issues, and understanding what needs are, and some things we can solve and some things we can't. But
Exactly.
the fact that they're able to have the conversation, that's the important thing.
Yeah, I'll try to continue to bring back what I'm hearing, from boots on the ground, because I think it's certainly helpful. Thank you for the time today.
Yeah. Okay. We're now on to EAP, RFP update and follow-up. And I have both John and Christy coming back. Is that correct?
That is correct.
Great.
Yeah, great. Thanks so much, Tom. All right, so from last month's meeting in October, we wanted to just provide an update on the EAP RFP and a little bit more information. So if we go to the first slide, first of all, just want to thank you all again for your comments and input from last month. It's just so important for us to really align with your vision and the importance of topics for the EAP RFP. And so I just wanted to show you all here the change of the weighting of those sections under the questionnaire. So it's not in my chicken scratch as it was from last month, but you can see it here as it's represented on the left-hand side. And again, really that access and network quality is getting the highest weighting there at 45%. And then the other key categories below that. The overall RFP weighting has stayed the same, with the 60% for the questionnaire responses, 20% for the financials and performance guarantees, and then 20% for those finalist interviews and references. If we move to the next page, again, just to revisit the questionnaire scoring process, is we'll be using a 1 to 5 score, and each evaluator, depending on their subject matter expertise, will use this scoring 1 to 5. Most of the questions are scored. There are a few that are informational only as part of the RFP questionnaire. And then finally, of those scored questions, some of the questions within the categories that are of high importance, for example, something that's a question relating to having a 24/7, 365 call center, that would get a higher priority and just be allocated double points. So on the 1 to 5 scale, a question such as that, if it's scored at a 5, it would actually be allocated 10 points, just to, again, weight those really essential questions higher. And then as we move to the next slide, I'm going to pass it over to John to talk about the selection committee and process.
Yeah, and again, we had hoped to rope in Brian to present these, but he's dealing with a family emergency. So I will make an attempt here, and Ali and Damien, feel free to jump in if I go awry. So the thing is, we just wanted to provide some context for the selection process. And so there's the selection committee, and that's formed most importantly of board members and then OHA staff and Mercer staff. And then there's the project management team, and that's OHA staff, Brian and his team, and our team, which is Christy, myself, and some other experts in the EAP field, and some project management support as well. So in terms of the selection committee and the actions that they perform, they'll, part of that is evaluating the RFP responses, and these the questions are assigned based on expertise. So there are questions assigned to OHA staff, Mercer staff, and to the board members, and Christy has pulled out a couple examples so you can kind of see what the board member questions look like. And then the role of the project management team is really the operational aspect. So we're setting up establishing the RFP and administering it, and we'll be doing that through one of one of our partners called Proposal Tech. So this RFP process will be handled online. And then we'll also compile all the scores, from the various people who are evaluating the RFP, and the project management team will ultimately make a recommendation to the board. And then the board makes the final decision in terms of this process. So again, let me pause there, and Ali and Damien, feel free to add anything that I may have missed. Any questions or comments?
I think that it was at the retreat where there was concern about that the big problem that we are having with the EAP, current AP, related to access and capacity, and it looks like you've moved that clearly as the #1 feature. And thank you for listening and changing it to reflect what the board members were feeling. So I feel like we're ready to move forward.
The other point to be made about that, Tom, is also in the finalist interview process that's something that will be highlighted. Access and capacity will also be highlighted as part of that interview process.
Okay, good. Any comments from other board members? My assumption is if silence means that your issues have been addressed and ready to move forward. There's silence.
We got a thumbs up.
Yeah. Super.
All right, and we're going to dive a little bit more. Oh, sorry, Tom. We have a few more slides.
The issue that that the board needs to come up with is who's going to be the board members on the selection committee. So I'll let you continue your presentation, and Ali, maybe you can tell us how you think we're going to be able to move forward with that after we finish the presentation. So back to you two.
Thanks, Tom. So John, I can jump in, and then I'll maybe you can interrupt me as well if I miss something. And so we really want to talk a little bit about board member participation. And so, first and foremost, it is at your discretion. Board members will, be scoring specific sections, based on expertise. And then our recommendation is including the less than a quorum of board members to be participating in the evaluation process of the questionnaire. And we've provided here kind of 4 questions that come out of the RFP questions that are samplings of what some of the board questions would be that you would be evaluating. And then finally, just wanting to call out that, participating board members in this process would evaluate the finalist interviews. And as John showed on that previous slide, that ultimately the project team then compiles all the scores and makes the recommendation to the board. So I'll pause there, and John, please interject anything I might have missed.
No, I think you've covered it nicely. Thank you.
Okay. My only, as a board, I understand the project management team would do all the collating and put together the scoring and come up with a recommendation. I would like to make sure that that recommendation had the thumbs up from the board members who participated, because if the board members who participated didn't agree with the recommendation, I would not vote for it. So having a one more bit in that process to make sure that the board members who participated in it agree with the recommendation is important, maybe critical. And I'm interested in your thoughts on it.
Whose thoughts are you asking here?
Oh, I'm asking the Mercer team who have just given us this proposal where there's, again, board involvement in the interviewing process and things like that. And then there's this project team that comes up with a recommendation that doesn't look like it includes the board members who've been part of the process.
I would echo Tom's concern.
Yeah, I was part of the last one, and when I got the recommendation and the go ahead, it was, as part of the participants, it was a shock when I saw the outcome. Right.
Yeah, and I think we would work to avoid those types of surprises, and a lot of that should come right out of the scoring, right? There's not, this is not, there's a process, there's a process here. We're saying what the rules are up front in terms of how things will be evaluated and scored, and so the recommendation should come out of that process, right?
Agreed, and the board members who participated should be able to be part of that kind of final conversation and looking over the numbers and giving it a stamp of approval.
That's the part that was.
Is there a problem with that?
Process.
Yeah. Is there a problem with that?
Again, I don't think Mercer's qualified to say in terms of the procurement process whether or not. Yeah.
Ali, I didn't hear you. I'm sorry.
Oh, I was just going to say, I don't think there's a problem with that. No.
Okay, great. Okay. I just
So this is Brian. I was just able to join. It
Hi.
looks at quite the opportune time. I'm sorry I wasn't able to make it until now. Is there anything you need me to weigh in on or address?
Brian, the only addition, could you go back one slide? Yeah, so Brian, what we were just talking about was the middle section where it talks about project management team that talks about setting up, compiling scores, making recommendation to the board. What's not included there is the involvement of the board members who were part of the selection committee. And I think there is there's interest on my part, and I've heard 2 other board members have stepped forward and said, yes, the idea of having the board members who participated should also be in agreement with the recommendation that comes to the board. My response was, if the project management team gave a recommendation that wasn't supported by the board members who were part of the process, I, as a board member, wouldn't vote for it. So, and I think that needs to be kind of closing that loop. Now, then John ended up saying, and it shouldn't be an issue because the scores will be the scores, and I agree with him on that also. But I think there's an interest, if board members are going to be involved with this, those board members should be participating in that final decision.
Well, so just to be clear, the reason why it's set up that way is for public meetings reason. If the board members who participate are part of the body that's going to make a recommendation to the board, that becomes a public body that is subject to public meetings law. And that's what we're trying to get away from during, at least for the selection committee scoring and evaluation. So, and it's modeled after previous RFPs we've done for both OEB and PEB, I believe, where essentially, we would make the recommendation based on the RFP rules and scoring. When we make the recommendation to the full board, though, there's no reason why the selection committee board members can't speak up and talk about their observations or how they feel about the recommendations. And they could, at that time, say, yeah, I don't know if I agree with that recommendation.
Yeah. So what, I don't want to carry on this. We'll take this to the leadership meeting that's coming up and talk through it and make sure that we figured out what a way to be able to take into account the recommendations of the or the thoughts of the selection committee board members. We don't have to problem solve it right now, but we'll take it on and come up with something that meets the requirements that you're describing, and also gives appropriate input to the board members who are part of the selection process. Can people agree with that?
I can,
Sounds good, Tom.
the comments we're making here, in opposite of what was just said, that we're trying to make improvements based on the fact that we've experienced the previous RFP process.
Yeah.
You don't want it based on the previous RFP process.
Right. That's what I hear. Okay. All right. We'll take this. We'll take this forward. John and Christy, I don't know if you're finished with your presentation. If you have more for us, head on.
I'm not sure if after the board, let's go, we have the selection committee. If we go to the next slide for the board member participation, and then finally is our RFP timeline. So you can see here what we've done is we are hoping to release the RFP on November 20th. And I know that we're working on, and Brian, I'm not going to speak for you as far as I know that you have a lot of processes going on at the moment with DOJ. So I'll pause if you want to add anything to that.
No, we're good.
Okay. And we've just highlighted here in pink just for board members to know that those boxes are kind of the time frame that for that evaluation period that your time would be warranted and needed. And then again, shows you kind of when the contract execution, implementation, and service delivery. And these are all subject to change, but we've done our best to lay out a timeline with lots of moving pieces as part of the RFP.
Okay.
I think that's it, Tom.
Okay.
Thank
Any
you.
other comments or questions for Christy or John about, or Brian? Thank you for joining us, Brian. Okay. I think we're ready to move on. Next topic is Ali, you're going to talk to us about the medical RFP follow-up from the retreat.
Yeah, thanks, Tom. Yeah, I wanted to follow up the board on kind of the high-level future visioning discussions that took place at the retreat last month. With a couple of brief updates, there was some really good discussion around where OEBB is as a program with, effective partnerships who share a commitment to innovation and keeping OEBB benefits top of class. I think, you heard that message from Georgianne earlier. And in fact, getting a huge group like Corvallis teachers in says a lot about where OEBB's at. But in the visioning breakout groups, we also did touch on what a potential medical RFP might look like as a vehicle to the future by way of time commitment and resources, and that the PEB board is seriously considering making this move. But based on your feedback, both staff and Mercer did not get the sense that the OEBB board was ready to make this a priority at this time, which is totally fine. I did want to mention the fact that the PEB board at their retreat a couple weeks after OEBB's retreat did indeed decide to make this a priority of theirs and directed staff and Mercer to start preparing a proposal for a medical RFP, which is going to take, at least a few months. But as a reminder, a medical RX RFP from conception to implementation is really a multi-year process. Just because PEB is considering going out to bid doesn't mean that OEBB must follow suit. So, but PEB went out for a medical RFP back in 2013, and OEBB went, much more recently in 2016-17. So, but there are considerations that the OEB board should be made aware of and have the opportunity to discuss prior to making a final decision one way or the other. Some of those facts are listed on this informational document, but really to close the loop on the retreat discussion, we just wanted to bring it back and to the board with a few more specific details of those considerations at a future date, so you can make an informed decision as a board. So have less of a visioning discussion and more of a factual discussion, really as a matter of due diligence. We'd much rather have the board have the discussion rather than have a legislator legislate something, which we've seen in the past. So that's why I wanted to come back with some more specific detail, like a timeline and the fact that contract staff will be tied up for some time, and just some of the implications. And from that point forward, it's OEB's an independent board, and you make the call for yourselves and your members. So with that said, any issues or questions?
Ali, my question is whether we can postpone our decision until, let's say, May or June of 2024, when we have, kind of gotten through the renewal process, and then still be able to, look at the synergies that having an OEB going out at the same time. Now, the PEB and OEB have some fundamental differences in terms of how they do business, in that PEB represents, state employees, and in many ways, OEB is creating an exchange for, over 240 entities. So it's and PEB is significantly going down the self-funded route, while we are essentially fully insured. So there's some substantial differences, but I'm just wondering whether or not we can postpone the decision to where we actually would be able to spend, kind of an hour talking through it all and
Exactly.
trying to
Yeah.
understand.
And it's such a big decision, and that's kind of why I'm coming back so soon, is really want to make sure that the board has the opportunity to consider it and make a decision what's best for the board, for the board and its members. And I think that we can get into the nitty-gritty detail, because there's a lot of differences and a lot of similarities. Essentially, if you were to go out for a joint RFP, it wouldn't be like for the same plan design or the same model. It would essentially be going out for whatever the boards are looking or seeking to get out of the RFP. But a timeline is obviously a real important part of that discussion. So that's kind of what we're still not completely sure of, Tom. We have to kind of see, we have to map this out and see kind of, if it could wait till May or June of this year to be able to look at like a 2027 implementation date. But so yeah, that's something that we can kind of continue to talk about in leadership meetings, and then find the appropriate time to come back and have the discussion with the board.
Yeah, Bill.
Just a quick question, to see if I'm misunderstanding terms, or my question is, would it be the same kind of synergy of staff time if we had two RFPs running simultaneously as opposed to a joint RFP?
For the most part, yes. It would be essentially the same amount of staff time. Maybe a little bit more, but not a whole lot more.
We could run it as two RFPs.
Oh, you're saying like two separate? Go ahead, Brian.
Oh yeah, this is Brian. Yeah, I think what we envision is something that looks like two parallel RFPs with, OEB having its own, focuses, weights, and maybe different plans against which proposers need to submit, their proposal, and PEB having a different set of, priorities and models involved in the RFP. There will still be a lot of common information before we get to evaluating those areas. I mean, basic, business information, making sure everyone's registered with the Secretary of State, sample contract, the legal terms, that sort of stuff is the efficiencies that we would still be able to achieve having two parallel RFPs versus a joint RFP if we define that as both OEB and PEB agreeing to the same priorities and same evaluation process.
Yeah,
It's the joint word that's causing a bug in me. Right?
Yeah, and I've tried to get away from using that terminology because it really is kind of two RFPs within just a procurement process.
Better
So
described
sharing,
that way.
yeah,
Okay.
Yeah.
sharing the processes and avoiding the duplication is understandable. OEB and PEB have some pretty significant differences, at least from my vantage point. And Ricky, I see your hand up.
Yes, thank you. You know, it is my understanding, it might be very limited, but for what I understand, this is a PEB priority, not an OEB priority. So I feel that there is two competing boards or two different set of entities. And if that's a PEB priority, that's great. That's for their own board, for their own leadership to decide. And I thought that legislator not too long ago removed that the RFP process had to be happen on cycle. So that's point number two. And my last point is if we look at the situation in Multnomah County on the Portland School District and other parts of the state, we are
I lost you. And
Yeah,
Did we lose him?
yeah,
We lost him.
Those are all good questions and fair points. And, I think that, it is the PEB board's priority, and that's not, and like I said, I mean, that's not OEB's priority. And it sounded like there's much less interest, and that's fair. I mean, that's absolutely at the board's discretion of whether they want to pursue this or not. But unfortunately, there's perception out there. Senate Bill 1067 a few years ago, that the boards aren't leveraging their purchasing power, and we looked at that very closely. And I think both consultant firms agreed that there's not as much leverage to be gained from 150,000 purchasing pool to 300,000. So we can argue against that, and I think that again, this would be more of a due diligence to really look at it closely as a board, and then we can come back, and say that that's been done, and the board passed and decided to look at it, when that duration of time, 10 years, say what PEB board is doing, comes up in 3 years. But I think a due diligence check is kind of what we're kind of pushing for here.
So I'm going to recommend at this point I don't hear a single board member saying it's my priority, let's move forward with this. We will, I think what we'll do is take this to continue the conversation at our leadership group, and see whether or not, again, I think we're pretty fully subscribed now for the next 5 months at least, through April. and as we go through renewal, and then think about bringing this back for conversation May, June, to make and because I read your sheet here, Ali, and I agree with some of the points there. I mean, I think there is rationale, and yet it's also I think we should think about it and chew on it a little bit.
Yeah.
And get through this process. And
For sure.
Enrico, you're back.
Yes, sorry, thank you. And my
okay.
last point was, this is through the community engagement that I have with, across the state, and some of the issues that we were facing or we heard as through Multnomah County when they try to do this sort of process as they work with their own health insurance through the Multnomah County. So I think this is a concern for me. We've seen the biggest city in the state have this issue. So I think we should reconsider or how to not set the priority that PEP wants into this board. So I would highly encourage us to, as you said, Tom, talk about it down the road, but I don't think this is beneficial for our members in OEBB. Thank you.
Yeah, thanks. I appreciate the feedback.
Okay. All right. So we will move on now to a CIAL update. And you don't have me anymore to do that. You've got Bill. Bill, you're on.
Yeah, and let me just say that for my first time here, you're gonna miss Tom.
Not true.
As I try and figure out how to best do my version of this. So we did have a CIAL meeting this morning, and we covered 3 topics. Clinical quality performance metrics from each of the vendors, talking about the various scores that we use for feedback over the last 2.5 years, and what we might be using for metrics in the coming years. And the second topic was clinical initiatives and the nutrition and weight management program options. So talking about the first group of things, which is clinical product performances, we had Kaiser come in and use their 2021, 2022. If you see the slides, it says MY, which is measurement year. One of the things to point out, two items to point out in the mathematics here is there's about a 9-month delay before these numbers are finished calculating. So when a performance year ends, you won't see this data for approximately 9-ish months. And when we look at percentile, we're looking at a countrywide percentile in the normal distribution curve to calculate those percentiles. So going through the concepts here, the key things that were coming out in the things was, of course, weight, BMI / other factors involving weight, breast cancer diagnosis, and others. Diabetes, which also followed a subcategory of statin therapy and the ability to convince members to receive statin therapy. And then your readmits for common or for regular stuff that requires an additional service for the patient. Going through those metrics, every vendor had, below average some of the stuff, but the common ones again were the statin and diabetes stuff. Cancer screening, weight assessment were kind of the key. All vendors had kind of a low rating for care, basically feedback from overall satisfaction things, but that seems to be a metric problem to me because it seems to be universal all around. Going on to the MODA side, they also reported in a scoring fashion, basically showing that, again, they were meeting, I should have said that Kaiser kind of meets all of the things, some areas of concern that we just discussed to work on in the past year. MODA also put up their numbers. Their points for their CCM were quite good, as good, in the same positive work. They had the same issues going on in their feedback as well. But the problem that MODA's having with some of their calculations is in their PPO measurements. The problem being that they're down, and I believe the number was around 20% of the MODA members are still in the PPO program, and these tend to be people who probably don't see the doctor, so they don't really have an interest in selecting a primary care home. And some of them are just those that are moderately in need of health care and don't want to change from who they have, want to stay with the person. So consequently, that score came in lower than desired, but again, around the same kind of assistance of weight management, breast cancer screening, colorectal screening, and poor A1C control, statin therapy things. And we also got a report from Providence. Oh, one of the things about MODA is they implemented a phone app to remind members if they choose to use the app about upcoming healthcare visits and things that they need to do, medication reminders, things like that. So they have a phone app now that helps members stay engaged. I'll get to the changes coming up here in a moment. MODA was followed by, hold on, I'm scrolling, sorry. Providence presented this morning. They also fell into the same categories. One of the things for those of you like me who don't deal with Providence in the PEB world, they have a choice program, which is kind of a medical home kind of thing where they use their clinics as a kind of a CCM type model that MODA has, and then a PEB statewide, which is their PPO kind of program, split slightly heavy towards the choice program versus the statewide, but near 50-50. And they are working on outreach, reducing disparities, especially in breast cancer screening, and providers as partners was part of their presentation. MODA and Kaiser each had some recommendations for changes to come up for the upcoming year. MODA is going to wants to change to a 5-point system instead of a 3-point system in their point scoring thing. It was kind of just a math thing, just basically split up the percentile weightings into 5 groups instead of 3. Fair enough. And well child visits are a new change that's coming from the government somewhere. And the changes that will be changed in the mathematical calculations are childhood immunization, immunizations for adolescents, and cervical cancer screening have some statistical changes coming in how they're calculated. Moving on to the second topic, flipping my page here. Sorry, I'm scrolling. And this was on the initiatives that we were basically coming out of our retreat that we had. So we're looking at some of the conditions that we were doing. Again, the shift left, the 3.4% cap, better education for our members, and quality and efficiency improvements. Looking at some of those things that were being related upon our cardio type stuff, including weight loss, and which leads us to some investigation that we're starting to work on in CL on GLP-1 type injection treatment for weight control. This is diabetic drugs, but some of them are now being investigated for weight control, weight management. We're also talking about different types of screening that are coming for cancer, including self-screening and some of the technologies that are being introduced to help members in their screening for earlier diagnoses of cancer. And we want to reduce the time to diagnosis and reduce the time to treatment on those things as a high quality, efficient member first care kind of setup. Also reminding of 3.4% cap. We're evaluating the weight and health, behavioral health for weight management from both Kaiser and things, and went through the different programs that were identified as potentials for us to do. Talk along those lines was to probably keep the number of available programs for our members at a high diversity because of the diverse ideas and concepts on weight management, and to but still keep an eye on the effectiveness of each one of the programs and just how well they are providing service to our members, so to speak, and how their service has lasting effects. Cancer screening. Cancer is still our second spend. I believe it was $26 million annual spend for routine screenings on 5 cancer types: breast cancer, cervical cancer, colorectal, prostate, and lung cancer. Cancer screening rates are varying but slightly higher on the 2023. We look like we're bouncing around the national or regional averages. Kind of things we could do better on those metrics, and finding a way to make that happen in our demographics is some of the discussion going on. And that part, just looking at how the government is changing cancer screening metrics or recommendations, I guess is the right phrase, and one's understanding how that affects what we're trying to do. There is, again, we talked about some technology going on where people can use some of the online and some of the, there's a phone app for doing mapping of your moles and things like that for skin cancer screening. Just looking into those kind of things. That one is actually done by OHSU. And, how to get early risk assessment and screening process into lead into high quality treatment. Timely diagnosis is kind of one of the focuses we're doing there. That, again, is kind of our outcomes that we talked about. We also talked about mental health kind of things, and bringing in the social determinants of health, and all the factors that go into health are not always in our control, that we have to look at the holistic picture of mental health. No magic pills here. There's a lot to it, and there's a lot of variety in how we go about doing that. And item 3, because I'm getting a little long-winded here, weight management. So we're talking about all the different programs that we have, which includes key factors of like mental health, things of that nature, as part of weight management, and how weight is looking at not just BMI, but how your weight management affects your other metabolic things like cardio and skeletal and things of that nature, how it affects with diabetes, hypertension, and various other factors. So looking at how our weight management programs such as Weight Watchers, Livongo, Omada, things like that are all affecting different portions of the weight management, or sorry, the overall health scheme of things, which includes all the way up to heart health. One of the things we talked about is how effectiveness kind of does a big climb up at the beginning, but then fades over time, and how that affects usage and metrics for how we're enabling things. But one of the controls that we need to do better on is using this kind of programs to control people's A1C who are greater than the 7%, and that management control versus people who are on these programs but have basically no change, versus people who have positive change and a slight small amount that actually have a negative change. So we go through those statistics, and again, looking at the whole cardiometabolic landscape, going from weight management through pre-diabetes, through diabetes, diabetes management, hypertension, in integrated behavioral health. A lot of the focus is how to get that all the way through to integrated behavioral health, especially on the GLP-1 drugs, which are labeled in the way that it has to include an integrated behavioral health program for those drugs to be, that's what's recommended on the label. Let's put it that way. That's how they're supposed to be managed. And just we put together some metrics on how to potentially look at our weight management programs to see how they should be invested in. But again, with the talk that we need to keep a variety of programs available to cover all of the needs of our various cultural and diverse background of our members. How about I stop there? Did I miss something?
Tom, you're on mute.
Yeah, I'm okay. That's why I'm not hearing anything. I was just checking to see if I fell off.
No, I
the
said
air.
thank you.
Okay.
No, it was me. Thank you. And
Okay.
it speaks to the complexity of the things that we talked about. The good news is CAO's job is to distill it and bring it to the board, these issues to the board. So the whole weight management, cardio, metabolic syndrome issues we're going to bring forward will continue to be looking at, as you described, the cancer, a lot of kind of interesting initiatives in that regard. So thank you. Any other comment from other CL members, or otherwise we'll move on to our second to the last topic. Okay, I have Kirsten and Margaret going to be talking to us about 2021-22 trend guarantee.
Yeah, and I'm going to step in for Kirsten to save her voice.
Okay.
So I'll be presenting.
Very good.
Next slide, please. So I'll go through it, Margaret, then I'll pause so you can add the additional details. So a little bit of background about the.
Yeah, sounds good. Thanks for jumping in, John, and just let me know if you want me to pick up anything.
Oh yeah, no, I definitely, feel free to interrupt me as I go through it, or I'll try and get through it and then give time to you to fill in the blanks that I'm sure to leave. So in terms of background, I think it's interesting that this is something that came into place in the 21-22 contracting cycle. And it was really a joint effort by the OHA staff, consultants, and the carrier partners to manage claims. And again, that's really its purpose. The purpose is to align OEB and the carrier financial incentives through a performance guarantee. And so essentially the guarantee is around maintaining a claim trend of less than 3.4%. And again, just as a reminder, that 3.4% is something that came about with SB 1067 in the 2017 session. In terms of fees at risk, so this is based on admin fees, and the maximum admin fees at risk is 5%. And this is excluding any taxes, and it works in the following manner. So the thing is, if the claim trend is 3.4% or less, there's no penalty. If it's between 3.4% and 4%, then there's a penalty of 2.5%, so essentially half. And then if the claim trend is greater than 4%, the penalty is the full amount, which is the 5% of administrative fees. And in terms of the calculation, without getting into the details, which I think are fairly involved, it really makes adjustment for things that would impact this, like changes in benefits, large claims, pharmacy rebates, and entities coming in and leaving OEB, and the risk of those entities that are coming in and leaving. And then it excludes the impact of aging. And then Margaret, feel free to jump in.
Yeah, no, I think that characterizes the adjustments. I think I would just note it specifically when we look at the cost growth year over year, it's taking into account those adjustments that you noted, John. and I think one of the considerations before the board is that there isn't a adjustment for something like a significant disruption to care delivery or pandemic or something like that. So we'll get into that a little bit more, but continue and we'll talk further.
So there's the background. Next slide, please. So here are the results. So essentially, these are the payouts for the 2021 to 2022 cycle. So 600,000 and 1.8 million for MOTA for a total of about 2.5 million.
And just to add a little bit more context or grounding here. So when we're looking at these results, this is related to cost growth for the carriers in the 21-22 plan year compared to the 2020-21 plan year as the base year. So this 21-22 year is the measurement year, and we're looking at year-over-year growth from the prior year. So the contract language is very clear in terms of how the calculation is done and how the costs are measured. Carriers did, as we, and the way this process works is takes about 9 months after the plan year ends for claims run out to complete. Mercer does a lot of actuarial work to crunch the numbers and do the calculations. And then we have, per our contract language, we have a period where carriers have the opportunity to review that calculation and offer comments or any additional information they want to provide. So I do want to acknowledge that in providing their comments upon reviewing the information this fall, as we were working through this with the carriers, both carriers did acknowledge that that these penalty results are consistent with the contract language. They agreed that per the terms of the contract and how the language is written and the requirements that they did not dispute these results. They did share some input related to just other considerations or thoughts. And one of the key considerations that came up in their input or comments was related to the base year, and that looking at utilization in 2020 to 21 as the base year, that was an atypical year for utilization and costs. A lot of care delivery was suppressed due to the pandemic, so that the cost growth observed in the subsequent measurement year, I think, trended higher than would have likely been expected in normal circumstances. And by normal, I mean not pandemic. And I hope that kind of accurately captures that sentiment that was shared by the carriers.
Thanks, Margaret. Next slide, please. Thanks so much. So the thing is, I think what's on the board's plate, though, is really to decide what to do about this. So there are several options. One is to collect the full amount, and this amount could be applied to the upcoming renewal as an offset to that renewal, or it could be added to the RSR, and that might have the same impact, but both of those two options. There's also collect a partial amount, and then there's also the third option is to waive the full amount that you saw in the previous slide. So I'll start through some considerations and then turn it over to Margaret for some additional ones. But I think one key consideration in making a decision is really understanding that the increases that OEB is likely to face in the 24-25 renewal are likely to be greater than 3.4%. So again, collecting this and putting it towards that as an offset would be helpful. In terms of maintaining the level of benefits, and things such as that. So, and recognize that there is the part of the challenge here is that the base year in terms of the calculation was the pandemic year, and so the thing is you're off a lower base in some ways, and so that's what's acknowledging in some of these other considerations. Another thought is that the renewal increases, even though the claim trend was higher than 3.4%, the renewal increases were below 3.4% in 21-22. And we talked about the extenuating circumstances, related to the COVID-19 pandemic. So year one being that 20 to 2021, base year being lower, and then higher claims in year two, based on some of the pent up demand, and, people's had worse, their health conditions got worse because of the pandemic and delayed care, and then higher provider costs related to the pandemic. The cost of providing care did go up. So those are some additional considerations. Just a quick note at the end here is really, after some discussions with the carriers of a technical nature, the approach to calculating trend was changed with regard to this guarantee for the 2024 year, 23-24 year.
So can I jump in now? Or do you have more data that you want to present?
No, that's it. I mean, unless Margaret wanted to add anything else for consideration.
No, I think in terms of considerations, that really summarizes it all. I do want to note, I think, we pursued incorporating this performance guarantee along with a couple of other guarantees where we have fees at risk, specifically a percentage of carrier admin fees at risk across PEB and OEB contracts, just as a good practice in the realm of performance-based contracting. This particular guarantee tied to the annual cost growth was also really intended to stay consistent and align with just overall statewide efforts to try to manage healthcare cost growth to a sustainable level year over year. And so, from that sort of philosophical perspective, I think it's really, I think it's a big credit to PEB and OEB that we have worked with carriers on these negotiations and incorporated this type of performance guarantee tracking into our contracts. So yeah. And I think, John did a nice job summarizing the considerations, so I don't have much more to add there.
Yeah, I'm going to jump in because I have been part of the conversation where we've discussed this. And when it was first presented, I said, well, it's in the contract, you follow the contract, except if there was an extraordinary situation. And the extraordinary situation happened to be a worldwide pandemic that dropped utilization significantly. So if there wasn't the type of increase in terms of utilization, it would have meant that our members wouldn't have gotten the services that had been postponed and delayed. And so this, while it was, as Margaret just said, appropriately trying to deal with cost trends and things like that, this seems to, personally to me, very punitive, and if this isn't the extraordinary situation to explain, how costs increased more than 5% in a year, when you had the trough of utilization associated with the first year of the pandemic. I don't know what, I can't think of another situation where you would have an extraordinary situation. The other part that I thought was pretty strange, and was on the previous page, is that it didn't adjust for aging of the population, which represented 3 of the 3.4%. Now, I think you could criticize the plans for signing a contract that didn't deal with that. And so maybe they should be penalized for, not paying attention to what the contract was. But from my personal feeling is, I think that this was a mistimed incentive that didn't deal with the what was happening in terms of utilization. So if you ask my opinion, we should be waiving the entire amount. So I'm interested in other comments. Bill?
Sure, I'm going to chime in on this one. Right, I have the greatest sympathy for everything that happened that year, and why option 3 on this slide is there, but I don't think it's a shock to anybody on this call that my primary concern is to keep out-of-pocket expenses and maximums to a minute at worst case condition is no change, if not lower, for our members. You know, with my MBA hat on, I know that the fee gets rolled around into the increase that's going to be presented this year, and we buy that down. So it all kinds of rolls around together, and I'm struggling a little bit just to ensure how I keep my priority number one on the three options presented here, which is to ensure that we keep our rates in the way that our out-of-pocket cost to our members at worst case stays the same.
So let's get other board members' opinions. You've heard kind of a couple different views of things. This is an important one for everybody to step forward and give us your thoughts. Okay, I'm not hearing any other board members' opinions, and I've just got a note that we've lost at least a couple board members from the meeting, and so the board is not going to be able, I don't think we have a quorum anymore, and so I don't think we're going to be able to take on this issue. I've got 1, 2. I'm not hearing from Bonnie. You're on. You haven't given me your opinion, your thoughts on this. Enrique, you haven't given me your opinion. I don't know. Susan, are you there? Sue, are you there?
I'm here, Tom. It's Susan Miller.
Yeah, your thoughts? Or you need more time to think about it?
I think I need more time to think about it. Again, it's Susan.
Okay, all right. Yeah,
This is
Sue, are you
Enrique.
still on? Yeah. Enrique, what's your thoughts?
My thoughts are the same. I think a major decision like this needs to be thought out, but I'm all about lowering the cost to our members when it comes to out of pocket and also when it comes.
Okay. It sounds like there's an interest in bringing this back to the next board meeting. And we will outline more information for the group to, might even do a straw poll ahead of time and get some ideas about what next to do with this. We'll give a couple options, and we'll see whether or not there's consensus amongst the board members. Is that is that how people feel good about pursuing, or is there another approach that people want to take?
This is Bonnie, and I think that's a great, I would prefer to wait and discuss this more.
Okay, thank you, Bonnie. We'll try to lay out, we'll get communication to the board members to think more about it and be more specific in terms of defining the options.
Tom, I'm back, and I will echo your perspective. Just get more information, as this is a big decision. But I was saying with Bill, lowering the cost of out of pocket, also lowering the healthcare costs overall in our packages to the members is the goal. And keep the same quality.
Understand where. Yeah, understand that. Great. Okay, so we are going to essentially table this for our next meeting. Any Ali or Damien, either of you want to weigh in on this, or are we have we finished this?
I think the board wants to move it to next month, so we're fine with that.
Okay.
If anybody wants to
Super.
send thoughts about what additional information they would like, please forward that
Yeah.
to Ollie and myself.
Okay, great. All right, John and Margaret, thank you very much for presenting the issues. I thought it was very clear what the issues are. The decision is not so easy, and we'll go from there. Thanks again.
Yep, you're welcome. We can put this on next month's agenda.
Super.
Thank you.
Okay, so the last topic we have is public comment, and we have two issues. The first one comes from a OEB member who wants to be able to unsubscribe from the email newsletter. Who is going to take this one on to discuss?
Sorry, I was trying to unmute. Do you want me to talk about it, Tom? This is Cindy.
That'd be great. Yeah, thanks, Cindy. Yes,
Okay.
I would.
Okay, so we have received this public comment. We have interacted with this member a couple times. And as you can see from the emails that we've sent you, he is really interested in unsubscribing, I think just specifically from our newsletters. Unfortunately, we don't have a system where you can just unsubscribe from the newsletter and stay subscribed in all of our other correspondence. So we have said no. Our biggest concern is that if we allow him to unsubscribe from all of our communications, then he won't receive any information about enrollment or any other critical information. We would just simply take him out and he gets nothing from us. So there is a potential maybe with our new system that we'll have the ability to do that, but with our current email system, we just don't have that ability. We do send 2 newsletters. One is at the beginning of the month, and it just is a very high level. Here are the webinars that we have available for you to go look at. The second one is the newsletter that we provide information about, specifically about benefits or wellness programs, other areas of interest for most members. So we don't feel like we inundate members. We try to make it a scannable. The email really is just a scannable. Here are the topics. You can click on this link, go to the web page, and get more information about the things that are of interest to you. So he did ask that we bring it to you. I think, Tom, at the time, I can't remember who the chair was at the time, but we did bring it to the leadership team and let you know that this was his interest, but he did ask that we bring it to the full board, so that's what we're doing now.
So the recommendation from OEB staff is that is to say, sorry, but in our current system, we are unable to not send this newsletter to you other than by taking you completely out of the system. Does he understand that if he was taken out of the system, he would get nothing in terms of like renewal and all of that?
Yes, he does.
He does, and does he still want to be out?
Yes. I think he would like, I'm not sure that he wants to be removed from all of our correspondence. I think ideally he'd just like to be taken off the newsletter, but we just don't have the ability to do that. So,
okay.
Yeah.
Is there, in terms of the, okay, someone just raised their hand. Enrique, do you have a comment?
Yeah, I guess my comment is that if we unsubscribe Jeff Gibbs, which that name sounds familiar, I concerned that he's not going to be able to get the information for him to get the educational piece about the programs and the subscriptions to the healthcare plans, everything that the staff and we all work for. because if he doesn't do that, then there's a possibility that can say, well, we didn't reach out to him, or we're not doing our job to provide him the options that he's entitled to by law. So I think that could be a slippery slope for us. So I'm sure there's a filter in his email that he can work on that.
Yeah.
Go to Don Howard. So I'm against removing him from the email.
Okay. Yeah. Is anybody in favor of removing him from? We don't have the ability to do the partial removal. That's what's pretty clear. That's what Cindy is saying. Unless someone is on the board, I don't know, even as a board member, what am I going to tell you to do? You know, other than do what we physically can do, which is to keep him on it and say we're sorry that you're stuck reading having a newsletter that you have to delete every month. It sounds like you've already pursued the issue. He ended up citing some rule, and it looked like we already investigated that, and our newsletters are outside of that restriction for like sending spam.
Yes.
Okay.
Yeah.
So
Jackie,
there's no
when Jackie was, yeah.
Yeah. So there's no we have no legal responsibility to not, you know, to stop sending him the newsletter. And the risk that, as Enrique is talking about, is that we then actually have the potential of denying him information that he actually does need.
Yes, and I just would like to add one more thing, Tom. When the Secretary of State's office did an audit, it was one of their findings was we're not educating our members well enough, and so these newsletters were directly in response to that that audit finding. So I would be concerned. Well,
yeah. I agree with what Enrique just said. You know, it would be a mistake on our part to actually follow through and stop sending him information. And we'll pursue our new system that would allow us to, you know, take people off newsletters, but we don't have that capacity now. Is there any board member that doesn't agree with what Enrique and I just articulated? Otherwise, we'll move on and give the OEBB staff the recommendation to tell him that we're unable to meet his request. I'm not hearing any other. We'll move on to the second public comment. The second public comment came from an individual who wanted us to include IVF coverage, and you've already heard that's something that we're actively investigating, and we'll be bringing recommendations to the board, and we'll be most likely including it in some discussion and some decision around benefits as we approach the 2024-25 renewal. Is that correct, John?
Yes, I'm having trouble with the mute button as well. I apologize. Yes, that is correct. That IVF is something that will be addressed in the renewal letter. Okay.
So I'm not sure who's Cindy, whether or not you're the person that would address, talk to this individual, but if you could communicate with her that we are actively going to be discussing this for the next plan year. We don't know yet what the outcome is going to be, but that we definitely are going to be moving forward with consideration. Any other? Will. Thank you. Any board comment on what we're talking about in just talked about in terms of IVF? Okay. So, Rose, is there any other public comment?
No.
Okay. So, if there aren't any other comments, I want to thank the board members for a pretty full day, and the we're moving forward, and we will get some additional information on this last topic, the issue around the trend guarantee from 21-22. All righty. Bye all.